coming to the last part of it. Before I start, thank you, Dr. Advani, for being there in the panel, and I would always love to have your expert comments whenever it is there. And if some of us is going wrong, sir, you can just pitch in, sir. So it's a short panel of 40 minutes. We'll make it to 35 to 40 minutes so that we can finish on time. And all the other esteemed guests are more than happy. I'll be more than happy for them to pitch in and just add a comment, because I feel this is a very important topic, very rarely discussed. We always have been speaking about lung cancer, breast cancer, and these topics do get left out. And I feel it's more interesting to do some webinars on these topics. So that's much more to learn when we present such things. So I'd like to invite all the 6 panelists. Dr. Ghanshyam Biswas, who's a dear senior colleague, who I've been seen him through my MBBS days. We have been one batch senior to me. He has been one batch in my same medical college. Ghanshyam bhai, welcome. From Bhubaneswar, oncologist. Neeti, dear friend, we did DM around the same time, 1 year. A friend here from Bhopal, roots from Bhopal, but now based in Bangalore, moved to a better city for better prospects, leaving me behind in Bhopal. So that's Neeti for you. So Reshma is there in Pune, a medical oncologist. Chandan, a friend, dear colleague from PGI Chandigarh. Aditya, Bangalore again. And Boven, nice to again connect with you, is from Kerala, Trivandrum. So coming to the topic now. What does a patient want at the presentation for metastatic disease? I'll skip this because I know all of us will tell that the cure is a rare possibility, but all the patient wants to live longer with good quality of life maintained. So now coming down to this. Neeti, if I can take first your comments, what is your minimum workup for any case that comes down to you as advanced RCC? Is PET scan, or PET scan is something that you don't do for all the patients?
After the histopathology confirmation, I would prefer either a CT chest, CT abdomen, pelvis, okay, or do a PET scan. I know for renal cell carcinoma, for kidneys per se, it's not a very good imaging, okay, but we would possibly have an additional imaging, and PET scan is good for metastatic disease. So I would generally do a PET scan.
Okay, Dr. Ghanshyam, anything specific in PET scan which goes over, as Neeti really pointed out, that for something as operable disease, it's not a very good modality where surgeons are very comfortable. HRCT chest and CT scan sometimes good enough. Anything as a medical oncologist, PET scan, you want to do something which you really get more data rather than a CT scan?
I don't think you do, because PET scan might pick up some non-avid uptake also, and we are not sure. So that is going to help you in diagnosis or not. The PET scan may be a one-stop solution, because if the alkaline phosphatase is high, probably again we have to add on a bone scan for such patients. So in that case, probably a PET scan will be a better modality.
Chandan, to pitch you in, 2 things. I would tell that PET scan is superior for probably the bone scan for bony mets. That's point number 1. Point number 2, if I look at tumor thrombosis, whether it's a tumor thrombosis or not, PET scan picks up it much better. Am I right on this part? Do you agree to this part of my PET scan conclusions?
Agree.
So now, Chandan, one more thing which I wanted to ask you. In PGI, do you do PET scans or a CT scan as a routine? Or
you're muted. You're muted.
Hello?
Chandan, I'm not able to hear you.
Yeah, most of the times it's CT scan, and we do definitely do PET scan also. But I must conclude PET is a better modality to identify. The sensitivity of diagnosing bone mets is much higher as compared to CT. It's around 75 versus 90%. That's the difference.
And what about a tumor thrombus? It's a much more better modality to do
thrombus too, because the surgeons always want the tumor thrombus is actually eroding the blood vessels or not. In that context, the CT is a better modality as compared to PET.
But there is also some data.
Point of view.
There's some data also to pick up whether there's a tumor thrombus, really a tumor thrombus PET picks it up better. But we'll stop here and to ask Aditya, would you do MRI routinely for every patient who is having RCC, or you do it for only symptomatic patients? A quick yes, no.
So routinely, definitely no. As the previous panelists have said, advanced disease, one-stop imaging, PET scan is one thing which serves all our needs.
Okay.
If there is a specific reason, if we are thinking about operating somebody, or if we know that if there is some kind of a hematuria going on, then maybe MR. But one-stop imaging should be good enough.
So to conclude, PET is, although it has advantages, you can always get away with doing a good CT scan and a bone scan. But PET could be advantageous if there's a metastatic disease, you want to quantify the disease. But one more thing PET could be helpful, which I find is if you're doing a TKI, sometimes CT scan do not pick up the lowering of activity. So that also probably helps us. So that's where it is. So anything is okay, but whatever you do, be constant over what you're going to do. So now the next thing is to Reshma. Dr. Reshma, do you really risk categorize every patient in the Indian scenario where 90% are unaffordable for anything?
So most of the times I do try to risk stratify, because then it does help us to guide the management. At least we can stratify the good risk into poor and intermediate. So even though these risk criteria have not really been validated as per their relevance in the current era, but still they have been used in trials, and that is how they help us guide therapy. So as much as possible, I try to risk stratify.
Okay, so you still
in the first line, not in the subsequent lines, okay. In the first.
I really put this up, really risk categorized. I'll tell you very honestly what I do. 90% patient cannot afford beyond a free student. So really then I feel, do I really need to risk categorize, because I do not go beyond that. But I do agree that once the affordable case comes in, I do take the effort of risk categorization. So Dr. Neeti, which risk categorization do you follow? The MSKCC or the IMDC? And for what reasons do you follow which one?
MSKCC risk stratification is what I follow, because it applies to most of the situation, whether you're trying to use immunotherapy or TKI-based therapy.
Okay, so you are using MSKCC.
And I would want to risk stratify all the cases to at least prognosticate them. I mean, I know how they are.
Agreed. So you can talk to them really how the patient is going to do. That's fine. Chandan, MSKCC or IMDC?
IMDC. I tend to do almost every patient categorized, but finally I may give a TKI.
That's fine. So why IMDC? You told is for MSKCC. Why are you for IMDC?
So there are few patients those who can really afford the TKI. I actually goes for the IMDC, and depending on that, I will give the TKI. In fact, the Pembro AG actually, those who are afford, I tend to give Pembro AG also.
Okay.
For me, IMDC is much easier. You have to do a CBC and the calcium only, right? So
all of us agree that the categorization is required. We need to prognosticate them. That's why final for on the panel. I just put it up because there is a difference in what it is. The basic difference is the lactate dehydrogenase goes away, and the neutrophils and the thrombocyte counts comes in. So basically, that one of the panel told that you just need to do a CBC, which will take care of the anemia, the hemoglobin, the neutrophil, the thrombocytes. The rest two are clinical parameters, and you just need to do a calcium. So that really gives you the easy part of it. So that's what is speaking of. If you look at here, it was my point against Neeti. What it was is the MSKCC is mainly inclined for the interferon era. So is it really valid? That's something which you want to put. And there's a beautiful thing that came up, which was put up in last year, I think so, which was a analysis with a retrospective in 176 patients in metastatic RCC, we treated with TKI as first line, and this was over 10 years period. They looked at agreement and disagreement between MSKCC and IMDC. And 77% there was agreement, and 1/4 there was a disagreement. And look at it, the majority of the disagreements when they found where they upgraded the MSKCC intermediate to the IMDC poor risk. So actually, if you look at it, this is where there's slight differences in the quarter of patients. You do find that majority of them from the intermediate will go on to the high risk. Anyone wants to pitch in a point here before we move on to the other topic and other things? Any other panelist? Quick point. No? Okay. So what do you have, Dr. Ghanshyam? This is a beautiful slide which I put up. And for Neeti, I'll just come in. Do you do the intermediate 1 and 2? Means 1 risk factor intermediate or 2 risk factors? And look at the difference in curves. There is a definite difference in curves in 1 intermediate risk factor and 2 intermediate risk factor. Dr. Ghanshyam, any point you want to speak on this?
So for me, a favorable and a poor makes more sense than this patient which comes in between.
Can you come again?
So for me, a favorable and a poor risk that stratifies treatment rather than the intermediate group, which makes much difference to me.
So it doesn't make a much difference to you. Bowman, if I can bring you here, do you agree with this statement?
Yes.
So for you, it's a poor or high risk. Intermediate does not make a difference to you.
It does not make a difference because practically it does not make a difference. So I don't think okay, on the theoretical basis we can have this discussion, but on a practical basis I don't think it makes a big difference.
Don't you think 1 and 2 risk factors, 43 months versus 22 makes a difference? Because when you're speaking of the survival, there's a gross difference. Chandan, last word.
Yeah, if you want to use Nivo EP, then you can differentiate between 1 and 2. In 1 risk factor, you can get away with TKI. In 2, I think you must give, if you have no problems, you can give IO combinations.
I think so. In the immunotherapy era, this would make a difference. I think we have to start getting more careful about this, but fair enough. We take these points. So now come to a case, a hypothetical case. A 57 years old male OPD, he comes to OPD with a cough for 3 weeks, with increasing intensity. It's a renal mass, bone and lung metastasis. We have done a biopsy. It's a clear cell variety. It is intermediate risk factor, and we put it let it be 2 as per MSK-CEC. We did the MSK-CEC. And how do we proceed? Any takers for surgery here? Bowman, surgery.
No, because this patient does not have any indication for surgery because it does not have any bleeding or anything like that. So we are not going to benefit out of surgery. So no surgery.
Pre-Caramina. Let's say this patient presents with pre-Caramina era. Would you do a surgery? With a disease bulk 90% in the kidney, there is a 10% disease bulk outside the kidney.
In that case, yes, definitely. If the bulk of the disease is inside the kidney, yes, I feel like okay, that patient might benefit out of that thing, and I give the option of doing an upfront surgery in that patient.
Even today?
That's what. It depends upon the scenario. Discuss with the patient. If the patient is okay, and then I know the evidence is actually moving away from that.
That's okay. Aditya, agree if today the majority of the disease is in the kidney, there's a metastatic disease, you would offer a surgery still in the intermediate?
No, I disagree because, at least in the post-Carmina era, especially if the option of IO-TKI or IO-IO combination is available, then probably does not make too much of sense in offering a metastatectomy, offering a cytoreductive nephrectomy.
Chandan. Yes.
The Carmina trial based on the IO therapy, right? The response rate is only 30%. So in 2020, I had therapy that can reach the ORR of almost 60%. Then I don't think surgery is getting more and more obsolete now, at least cytoreductive nephrectomy. And if I stratify the Carmina depending on the risk stratification, cytoreductive surgery is only for the good risk, not for the intermediate and poor.
Okay, Reshma, let's assume that you get the IO, and let's say TKI. You gave a TKI for whatever reasons. And this patient somehow does very well. Again, comes back to you on 18 month, still has a very good response. And would you consider a cytoreduction later on? Have you ever done that? Would you consider that? Do you have data for that? 3 questions.
Sir, if he has a very good response and there is data for delayed cytoreductive nephrectomy, so we can offer them this option if there is a good response, tumor bulk is in the kidney, because even though the survival data is not there, but there is some data for delayed cytoreductive nephrectomy.
Niti, with your experience, Reshma tells there is no survival data. To my knowledge, that the curves really separate out. Do you think there is an advantage of going and offering some patients a delayed cytoreduction?
You actually answered it. For very unique subset, yes. If a patient has had excellent response, I mean, let's say the bone disease and the lung disease has shown an extremely good resolution, and there's a small residual disease in the kidney. So in that situation, it might be a unique situation in which probably an interval cytoreduction might be.
Anyone in the panel has experience of delayed cytoreduction in any of the patients?
Yes, I have experience. One of the patient was on recently underwent. He had an excellent response to the TKIs, and then because the patient symptomatically became better, weights, he had a significant gain in weight, the reduction, the metastatic site had a significant reduction. And the option was given to the patient, in fact, so it went ahead with the interval cytoreductive surgery.
So basically, all of us agree that at this point of time, with this era, cytoreduction at the upfront should be not put up for the intermediate. The low risk, it's fine. And if there's a very good response, there is data, something that's evolving for the delayed cytoreduction.
Yeah, the TP. So I have another experience. So the patient was doing well. So sometime back, the patient actually had too much of local symptoms. So pain, hematuria, so that appeared. So there I had to consider a delayed surgery. So it is in contrary where the responses was not good or the patient progressed from the initial treatment and the local symptoms were much more. So the patient needed actually a local care. So that was more important. So that's another scenario.
So now we come down to Aditya. So this patient, no surgery. So which is a combination of choice? Intermediate risk, metastatic, bone and lungs, clear cell variety.
I think
Dr. Raja.
I think cross-trial comparison might not be too fair, but I have had 3-4 patients with this combination in whom I have used IO-TKI combination, one of whom in fact achieved a complete response.
So which is the IO and which is the TKI?
IO would be pembrolizumab and TKI would be axitinib. So since the time that the pembro axitinib data has come out, I have used them, and having seen a complete response in a metastatic disease, that did blow my top off, and I'm actually quite favorably inclined to that. And just to make a point about previously what Dr. Boban said regarding the delayed cytoreductive nephrectomy, I think that approach will help us select with the disease with the favorable subtype. So if a disease is responding to TKI, that's when we try and do more interventions to prolong the survival.
I think all of us agree that there is a very select patient who can go for the delayed. We'll stop the surgical part and come on the med-onc part. And then TKI with ICI or IO, what our previous speaker spoke about.
Both are correct, but
what do you choose?
In the present situation, I tend to use pembro and axi because it's very difficult to procure the ipilimumab. So
if it is available at this point,
I would have chosen that also. But the point why actually saying Nivo EP is I think I may choose Nivo EP because EP is given for the four doses, right? It's only for 4 doses. And after that, you have to stop the EP and you continue with nivolumab. There is no long-term kind of giving ipilimumab.
Yes.
So if you compare the TKI and IO, pembrolizumab has to be there, but TKI has to be continuously throughout the time period. So in that way, EP may be a better option. But
apart from that, if I have to choose, I know both these things are approved. We saw that. But the highest response rates ever seen in RCC has been with the IO combination.
Yes.
So in that, if a patient is affordable, what stops me, Rishma or maybe Dr. Ghanshyam, he can come in, anyone can come in after that. How do you select a patient between a IEP and a Nivo combination versus a TKI and a immune checkpoint inhibitor?
Sir, I just want to comment one. The early progress, if the IO combination is higher as compared to the IO and TKI, if you are
17% versus 10%, that I saw that data is there. So I will come to that in the detail. Reshma.
Sir, there is no head-to-head comparison between both of the arms which you have said. So what we have good response rates with the IO combination. So but considering I have no experience by using ipilimumab, I have used exotic pembrolizumab. That is why I have used it in 3-4 patients. Unfortunately, those patients couldn't continue it. They had good responses, but because of the money issue, couldn't continue it for a lot of time. But since I have experience with exotic pembrolizumab, I would prefer that.
Niti, your choice, and then Dr. Ghanshyam. The same thing comes in. When we speak to our patients, do we counsel them enough that you have to take it for a particular considered period of time? So if that is not done, did we benefit the patient, or did not benefit anything? Niti? And what will be your choice here?
So my choice will be IO plus TKI. If I have finances which allow me. As Reshma also said, IO plus IO and TKI plus IO have not been compared in 1:1 comparison. So we really don't know whether it's superior. And of course, I don't think we have too much of experience, at least in our country, to use EP.
Okay.
So I generally use IO plus TKI.
Dr. Ghanshyam.
So I have an experience of a patient who had early CKD with the comorbidities. So he was somewhere started on pajapinib, came to us 2 weeks later with GI toxicity. But once there was control, the patient was switched over to axitinib and pembrolizumab. So he has been doing good, so no toxicity. Now the problem is that every time he comes, so doctors are asked to not in that, which is a very difficult scenario. So that's the issue.
Woman, before we move on, a combination, which one first? With the TKI and ICI. If I see on the NCCN, that is also the third approved drug which is there as a first line. Anyone? Or anyone has experience with cabozantinib? No? Okay, we move on. I think that is the third drug that is approved. Debulking surgery, I'll just skip because we have spoken about it. So this is what it is. So we'll go to, there's a rationale for combining the immune checkpoint with the VEGF TKIs, because the VEGF TKIs actually augment the immunotherapy action. That's what it is. All of us know this. Just to come to one point of it. Does anyone do any PDL testing? Chandan, do you do PDL for any of your patients whom you consider? Do you do that?
No, sir. No.
Okay. Anyone in the panel does that? Anyone does tumor mutational burden, TMB, something to keep this better?
I have done in the past, but not recently. I'm not doing. So the PDL one. Initial days, the recurrent metastasis patients we have done, few patients. So the last 2 years we are not doing PDL one.
Okay. So tumor mutational burden, no. PDL one,
no.
That's the two things that's coming out of the panel.
The only thing is that we don't do PDL1 at all, but in some patients we ask for the somatic mutations panel. So that normally will include tumor mutation burden, PDL1 and spectrum of mutations. So I mean,
any lab where tumor mutation burden is validated in India?
No, most of these what we send would be foundation one. So
okay. That comes automatically. Yeah, Chandan, you want to tell something about it? No, all this. That's okay.
No, it's
okay. So the only thing that comes out, this is what it was speaking about. So if you look at it, if you look at the pembrolizumab, the progression disease is around 10%. It is 17% to sunitinib, which is actually matching the data for the immuno combination. That's also the progression 17%. But look at the CR rate. The highest CR rate comes with the immune combination, and that's the one point of the immune combination. Not only the response rate, even this combination. All of us have seen this. I'm going to skip this data. There's the data difference. There is no group that really is superior or inferior. Javelin, as Dr. Raja told, I'm not going to tell about it. We know that the axitinib, avelumab, the OS data is, all of us know that. But here again, the response is not much different for the PDL1 and the overall population. It's actually the same. So PDL1 does not much score over the overall population. The same thing on the curves which are seeing both the PDL1 positive overall, it's actually the same. So the OS is no different. I'll just come to this part of it, that combining. So which Chandan told, I'll just come here. Just look at this part. The progressive disease is little higher for the EP and nivolumab, but the complete response rate are still the highest in this group. And the response rates are still the highest what has been seen. So can we conclude that if I have a bulky disease and the disease load is high, I would be more comfortable if everything is there and EP comes to the market, I'll be combining both? Reshma?
Yes, so from this, because of the highest, yes.
Okay, Chandan. Any points?
So I used for just one patient only, but I feel it's a doable.
No, what is the data? I understand all of us are very rare experience. With the data, do you feel for bulky, because of the response is more, you'll be more comfortable doing the EP and Nivo?
Yeah, I'm happy to use. I have no problem in ipilimumab.
More symptomatic and bulky disease, probably the combination will be better, no?
I think the most important point, just to make the patient understand, it's epilimo requires some time. That's a time lag to prime the lymphocytes, right? So you actually have a patience for a few more times, then it will work beautifully.
Bowman, any experience with the EP and nivolumab?
No, I don't have any personal experience.
So now do you feel there's a patient selection where you would like to use it? Because if you look at the data which Dr. Raja showed, which I will just skip because that is also data that it is a response to this combination. It has the highest, the flattening of curves happens with this combination only. If there's a response in the responders, actually the curve plateaus out. So do you feel that this is the combination for the future?
Yeah, theoretically, yes. It looks like the data looks very promising, and definitely it's going to be the future. But as of now, from the practical point of view, I don't have any experience, but hopefully in the future we'll be able to use it.
Aditya, when it comes in, the market is full. Are you convinced, or still you will be watching?
So, Dr. TP, the issue here is, see, as per data, the IO-IO combination is good, but the actual googly in the picture is what happens to patients who progress on a IO-IO combination. Would you really want to use a TKI? And if somebody has progressed on an IO-TKI combination, then what else to do? So, I think there are more questions than answers for this issue.
But at the first line, that's what we are speaking about. What the data tells you, again, the PDL1 does not change. The only thing this curve tells you that sunitinib is the inferior arm. That's what it comes out. Both the black lines are the inferior one. So, this is what it was. Yeah, this is what the curves are. The nice separation for the responders.
If the possibility of drugs is there, then IO, yes. And then second line, we can think of cabozantinib.
Exactly. I was coming to the second line. So let's assume a poor patient, which 99% of my patient category is. Which is the TKI which one chooses? So what I conclude from the combination first line is that because of the experience, and if he is not there, we are a little skeptical. We are choosing the combination of pembro and axitinib. That's the first #1 choice. Cabozantinib, although approved, people are skeptical because we are the drug that is unknown to us till now. The thing is that IO looks the most promising, and all of us will like to use it. The data is the most promising among all of us. That's the fine for the first line. If TKI, which one? Dr. Ghanshyam, which?
Yeah, so we have already moved to pazopanib.
You are a pazopanib guy. You are a pazopanib guy. Okay, Aditya, quick.
If cabozantinib is available, I would want to go with cabozantinib in an intermediate poor risk.
So you would like to go to cabozantinib, but if it is available, what is the choice now, pazopanib or sunitinib?
Sunitinib,
sunitinib.
2 weeks, 1 week off is good for my patients.
All of us do that 2 week, 1 week. Chandan, which one?
Sir, the patient-friendly pazopanib is my choice.
Okay. Niti?
One of the two, sunitinib or pazopanib, generally sunitinib.
Generally sunitinib. Reshma?
Sir, if affording sunitinib, if not affording pazopanib. Pazopanib, sir, is more tolerable, I think.
Both turn out to be the same cost in 1 year. That's the real data. Woman, which one?
Sunitinib.
Okay, I am a sunitinib guy myself, I'll admit that. If there's a chance, I go with sunitinib just because the bulk of the evidence has come from that. I feel comfortable now managing the toxicity. But pazopanib is a friendly drug. That's no doubt about it. And there's nothing wrong about it. To tell you, all of us know this, both are equal. Pazopanib was patient preferred. The tivotinib was better than sorafenib. We saw that on the data. The cabozantinib is better sunitinib in regards to response rate and PFS. The OS data is still there. In the Indian scenario, we have spoken. We'll skip this. Just to tell you that one data which I could pick up, I maybe missed some data. I'm sorry if anyone has published, I could not pick it out. This is data from Kidwai, my alma mater. They have a small data. You can criticize it, but all this says that sunitinib, pazopanib both look same. The sorafenib is the inferior one. Coming down to which question was asked, how do we sequence? If you look at the metastatic RCC progression to first line, maybe a TKI, then cabozantinib, Lenva, everolimus, and nivolumab comes in. So, any takers for everolimus? Anyone who use everolimus at this era as second line?
That was me. So yeah, low dose everolimus with lenvatinib.
So you use low dose everolimus with lenvatinib as a second line?
Yeah. Yeah.
Okay. Phase 2 data you are quoting. Okay.
Absolutely.
So that's your preferred second line, lenvatinib and low dose everolimus.
Yeah, absolutely. Because the standard dose of everolimus definitely the toxicity, and a second line IO for most of the patients is not affording, so that makes a better choice in the patient scenario.
And then what is the second line choice?
My options are nivolumab versus everolimus.
So that is again the two choices coming. Niti, your second line choice?
Generally Nivo, if not given in the first line. I mean, if IO was not given.
That's fine. Agreed. If not given, it's a second line choice for you. If not Nivo, not affording for Nivo.
I mean, I would consider either single agent axitinib or if I have given. So I mean, we have generic axitinib also.
Yeah, and now we have generic axitinib.
And lenva everolimus, I would possibly use later down. So I have third line if possible, then yes.
There is the data to that. Actually, this is one combination which is active on third line. So to be fair to what Niti told, this can be reserved for even the third line. And there is activity still of the lenva and everolimus in the third line. Very fair comment. Reshma, second line choice.
The second line choice is single agent nivolumab most of the time. And if the patient is not affording, so nowadays a lot of generic drugs are available like for axitinib. So we are if not affordable for nivolumab, then any of the generic options.
Okay, Bowman, any thoughts?
I prefer everolimus single agent also, because I have seen good response in a good number of patients. But the thing is that we need to know how to manage the toxicities. Now all of us know how to manage the toxicities. So yes, everolimus.
Are you really convinced that it's the best agent as a single agent?
It works not in all the patients, I'm saying, but then if it is working, it works. So that's my take. If it's not working, I will add lenvatinib to that thing. That's the way I go.
Okay. So can I conclude for this line that cabozantinib, if available, is a good choice for people? Otherwise, nivolumab is definitely what people prefer. Because it's not there, we are there at takers at this distributed between lenvatinib and the low dose everolimus. So this is the data which all of us spoke about, and it is a very clear thing that everolimus really is the inferior arm in most of the trials, and definitely sorafenib is not there at all here. I'll just skip this to tell you which sequence makes better. There is a data for that. You can criticize the data. It is the sequence which was pulled out post pazopanib or sunitinib, which is the data after TKI, which is the most affordable thing. It comes out for two things. That the blue line is the nivolumab. So nivolumab is the most cost-effective sequential therapy. The second one is cabozantinib. So these are the two most cost-effective sequential therapy after a first-line single agent TKI. So any different ethnicity, anyone can take it. There is data for that, toxicity versus efficacy. Bowman.
Yeah, definitely. Ethnicity plays an important role. All of us agree to that thing. But then we don't think
in regards to toxicity, or both.
Both the ways.
Okay, that's it. Aditya, what is the point? Toxicity and response.
Especially with regards to toxicity, ethnicity definitely makes a response. I mean, different, because response-wise we know that there is difference, but especially when we use sunitinib, and just like you, I am also a sunitinib guy. So for us, when we started with using 4 weeks on, 2 weeks off, it was terrible. Then for we shifted pazopanib, and when 2 weeks on, 1 week off came, even in that, most of the times I end up going down to 37.5. So Asian ethnicity, the tolerance is definitely lesser than Caucasian ethnicity.
Okay, Ganjambai, any thoughts on ethnicity? We or East Asians do differ in toxicity, outcomes, or both?
We are seeing with capsaicin, we are seeing with EGFR TKI, and these are also BJP are all the same. So probably our patients, our population are a bit different.
Let's see what the data is. We may assume a lot of things. The data is active oncology data. It's pulled out from all the publications, the more than 1,500 publications. It just points out two things. It is the Caucasians and the Asians. Just look at the hand-foot syndrome and thrombocytopenia. And these are the two toxicity which really matters in Asians, which were much more, but the outcomes were no different. So basically it points to a conclusion. Asian patients more frequently experience sunitinib-based toxicity such as hand-foot syndrome, fatigue and thrombocytopenia compared to Caucasians, but there was no difference in efficacy. This is what the data stands. Anyone wants to counter this? Chandan, you want to tell something?
What we are actually, we are not Asians, we are not Caucasians, right?
We are more like Caucasians. That's what people are telling.
Yes.
We are the darkened Caucasians. That's what it will be more likely. So there is one data which I could put up that has come from AIMS, I think so. And this data does tell that the lower dose pazopanib, they found that little more toxicity was there compared to Western population. There is still a very retrospective data, is not of high quality, but that's the best I could find out. Last question. Any one of you remember last when you referred it for radiotherapy, any patient of RCC metastatic advanced?
Only if the brain mets or bone oligomet.
Leave the brain mets apart. Last patient, anyone had referred?
Yeah, hemostatic RT. Hemostatic RT. Done, yeah, done.
SBRT for the isolated bone mets, SBRT.
Pain agreed, brain mets agreed, hemostasis RT agreed. Apart from these indications, classical, anyone thought of anything else?
SBRT. For
SBRT. Yeah, when was the last time you sent it advanced RCC for SBRT?
Rare, very rare.
Okay, so I find out some evidence, and this is something I don't advise this. That's very clear. This is a disclaimer. I don't want to advise, but let's see what it is. It's the data which I feel as a medical oncologist we keep our eyes shut, and we should look at this again at data which is the prospective sematic-centric. In a symptomatic patient, there is a very good response rate. We're looking just as the responses. There's a beautiful responses that comes in with SBRTs. And what they wanted to conclude here is, they wanted the NCCN to evaluate SBRT specifically in 2 or 3 conditions. That is the treatment of residual lesions in the kidney and treatment of previously inoperable RCC and adjuvant treatment for high risk. There's no data for that. High quality data is not there, but that is what it is all about. So to conclude, if you look at it, sunitinib has a response rates of around all risk 27%, but the highest response rate comes with the axitinib, pembrolizumab, and the EP and the nivo arm. These are the 45 to 55% of the response rates. We have seen an increase in PFS from 5.1 months to now at 15.1 months. And look at this data. We do find the interferon era is gone. It is only for a very select few. I don't feel any one of us does that now. We now know that TKI is already there. The combination of TKI IO and the IO and IO is there to stay. I don't know what the future stands. But one thing is there. Look at this. For the 3-year survival from the interferon to where we have reached today to this part is a huge 3-year survival which is touching around 35, 40 to 50%. And that's what it is all about, RCC. So to answer that last question, to conclude, if you use a TKI, cabozantinib, sunitinib, pazopanib, you still can go for immunotherapy as a first-line choice. You can go for a TKI to a TKI, as Dr. Raja told, if the response is very good to the first line, you can just switch over to a TKI even a second line, means more than 1 year of a PFS. If there is a poor PFS, probably immunotherapy is a good choice for us. But if you use immunotherapy, still you can use TKI in the second line, and cabozantinib is a good choice. Lenvatinib, everolimus, all the phase 2 data, there's good data to that. Axitinib, there's data post TKI to TKI. But most of us refrain from using TKI post TKI. So everolimus, I found one of our panelists very eager to use it, but the data is most of us agreed that although it can be given, it should be not, the response is not huge, and it has been shown to be inferior to majority of the combinations. So that is it, what I wanted to go through. And if there is anything which I have not spoken about or not done about, any of the panel wants to tell last few words, because we have 1 more minute left before this ends.
Sir,
please, Dr. Ghanshyam, any last words? Just hold on. Dr. Ghanshyam, any last words?
So I had a trial of a bevacizumab interferon, generic trial. So I put few patients, 8 sort of patients who are exposed to all TKIs basically. And out of these 6 patients, so there are many patients with diffusion, there are many patients with severe bone pain. So at least they have received 3 TKI in the past. None of them are IOs, but they have a really good at least a symptomatic disease control. So it was basically bevacizumab and interferon.
Okay.
So there are some patients probably who cannot afford for an IO. So this is a viable option for many patients. So at least a symptomatic benefit.
Let us hope so. These benefits. We also had a trial first line for temsirolimus and the BEV. That trial, we know it was a difficult drug to handle. Chandan, any last words?
Sir, what about Atejo and BEV, which yet not approved by FDA? I think there is another options for the patients in first line therapy.
There is the option of Atejo and BEV. Even you, Dr. Raja rightly showed, there is even an option of put on a nivolumab progression and adding the second immunotherapy as the ipilimumab, and some patients have benefited. So I think what we spoke of was standard options, but these are options which all of us can go through. Dr. Neeti, any last thing which we missed and you want to comment?
No, I think how everything was covered, but I just wanted to say that, I mean, over the past 15 years, we have done several trials on renal cell carcinoma, multicentric trials, and most of the drugs have done so well that it's very hard to decide which one. In one era, one did very well, in the other era. So we had temsirolimus that you said, we had complete responses, we had high dose interferon like bevacizumab, we have patients with complete responses which stayed for very long. We had axitinib trial in which people had actually complete remission for 15 years. I mean,
it's good to have choices rather than not to have any choice at all. So at least that's the best thing that's come. Dr. Bowen, any last words? No? Okay. Aditya?
I think RCC as a disease is such a heterogeneous disease that we will always have a set of patients who will do well whatever we give, and another set of patients whom we still, whatever we throw at them, even if we throw IO, they might not do so well. So a lot is yet to be learnt in this disease, and as Dr. Neeti said, over the years we will have our favorites and hopefully our patients benefit from it.
So the last is saved for the best. Reshma, the last word.
Sir, actually, when I studied in JCRI, so most of our patients couldn't afford anything, and most of them were on sorafenib only. So I just wish there was a little call on more generics would come up so that people can start affording. Otherwise, I mostly feel most of the patients land up with taking sorafenib only.
Yeah, please tell me. Complete. Sorry.
I have one question. Is anyone using single agent pembrolizumab? Because there was some data on that also. First line single agent.
First line, I think so. That data was showed by Ullas in his slide, and when he compared the patients with non-clear cell variety, there was an arm of clear cell variety also. Ullas showed that, which was published this ASCO. So I would just like to point out and end up with one of their patients, which Reshma really reminded me of. The patient, post 6 years, is still on single agent sorafenib and still doing well. Then now he manages his own sorafenib. He comes to me now once in 6 months. Doesn't even bother to meet me once in 2 months also, and comes to me just to tell me that I am fine, doctor. I'm really surprised what happened to the patient. How
you must start sorafenib and see that this patient will continue to respond.
No, I'm telling you why. I have the slides. I have that. He did not have any. The bone scan or the MRI did not show any bones only. They're all decalcified, all huge bone metastasis. I'm still surprised. That is one patient that reminds me whenever I do RCC panel. With that, I thank. Neeti, any last
one patient in, I think 2007, we started axitinib trial. 14 years he's doing well, and he comes every time, no disease.
All of us, I knew axitinib is a good drug, but sorafenib, we just excluded the drug. Still, that patient is doing well on sorafenib. That's what I want to tell. So, thank you all. Thank you, Ashutosh. Thank you, Adley. Thank you, all my seniors, and for this nice opportunity. Thank you, panel, for making it active. I'm sorry if I had missed someone or if I have not given enough time to anyone. Thank you. Ashutosh, please.
Ullas.
You missed me.
Ullas, you are so there's nothing I should thank you for. Okay,
Thank you, sir. Now may I request Dr. Advani, sir, to give the concluding remarks and key take-home message from out of this webinar. Advani, sir, please.
He's not there, actually.
Dr. Raja can conclude, actually, if he's not there. Dr. Raja.
Thank you, Sahoo, for sudden role, but excellent discussion. I think you covered all issues and across the spectrum. And I heard, I think Dr. Neeti and many others speak. One point that was striking is each one has fallen for a drug. Can I say first love is the best love? good impression with you have experience, and then that experience, you have a very good experience that it sticks with you, convinces you, and then it really, how do you learn to handle is also very important. I think you touched upon all spectrum. The only couple of points, if you permit me to add,
sure, sir.
In the ideal scenario, the spectrum of responses that you showed, you yourself showed that the topmost response has come with pembrolizumab around 56%, and then avelumab and axitinib around 52%, and then IO is around
42.
40 around percent. So what is important is that if you look at, somebody asked about pembrolizumab single agent strength in RCC, and what the IO does is the early fall that happens with IO, the early losses is mitigated by the VEGF addiction. So that is so patients who are really bulky disease and has got a symptomatic disease, I think IO is okay, but the TKI must be there to salvage it. So that's the point. IO plus IO alone will not give that early start for you. And if you have a good patient who is going to, and then you are looking at a long-term and flat curve, and the advantage of only 4 doses of IP, and then convincing and convenient to continue, very easy to continue the doublet. I have 3 patients on doublet on renal cell carcinoma and some other patients on lung cancer. So I can tell you that it's not difficult to do, it can be done. Whereas if you use a pembro plus TKI, the toxicities later on is significant when you have both. So these are some of the points.
Sir, can I ask you one thing, sir? With your experience, probably you have the largest experience in the whole panel here. So can you tell me which is your choice now for the affordable group? It's a IO or a TKI IO? So there's nothing but to choose between both of them.
Right. So as I told you, I would think about 3 options. I would think whether I will choose a single agent TKI, practical, cost, etc., or whether I can use a doublet. If doublet, I would say that whether I can use pembro axitinib in patient who has kind of symptom. If I think the patient has got a symptomatic, something like a visceral crisis and all.
Okay.
But if a patient is good, stable, I would love to go for the IO so that I am looking at the advantage of those flat and all that. I want to draw a corollary to another subset of disease. Ullas is there, I don't even dare to talk. But that on 9LA and everything convinces that the first 2 doses of chemo adds something to that IO. Remember that the initial kickstart is given by something that you do upfront, chemo, or here it's a TKI. So these are some of the things that I believe.
Last question from my side. Any intermediate risk where you consider single agent TKI?
Obviously, practically, that's what most of the patients do end up. But now I will be seriously considering the doublet therapies in several patients, or practically in all patients. I won't tell myself I'll consider it like you would consider an allogenic transplant in all patients with high-risk leukemia, and then you end up doing something like that.
Okay, thank you, sir. Thank you, sir.